Good morning, everyone. Second day of the Pain in Europe, the 13th European Pain Conference here in Budapest. My name is Morten Høj. I have the great pleasure of interviewing today Winfried and Rianne, and we're going to be talking about the status, the current status, and presumably something about the future of pain management post-surgically. But before we do that, I would leave it to you to introduce yourselves, and obviously we should start with you.
Thank you very much, Morten. I'm very glad that I'm here. My name is Rianne van Boekel. I'm living in the Netherlands and I'm working at the University Medical Center in Nijmegen. And I'm working there as the head of the pain and palliative nurses team. And I'm also a pain nurse from background, but I've done my PhD in 2017, being an epidemiologist as well, and a teacher at the University of Applied Sciences, also in Nijmegen. Thank you.
Well, thank you. Winfried?
Yeah, my name is Winfried Meissner. I'm anesthesiologist by training, and I'm head of the pain unit and also of palliative care unit. So I also do both. In terms of clinical work, my focus is on acute pain, postoperative pain, and also in terms of research. I do mainly clinical research in the area of postoperative pain.
And you are at the University of Vienna?
Yes, I'm working in Jena. Jena is a small city, more or less in the middle of Germany, with a very old university, and that's where I'm working.
Very nice. So when we talk about post-surgical pain, we have this, for pain researchers at least, we have this nice model. Because we have people who come in with a certain amount of pain, or maybe even without pain, and then we know what we're doing to them. It's almost like an animal model, if you excuse me. And then something happens. And I think what we may do is talk about the acute onset of pain after surgery first. And I don't know if you want to differentiate between people who had pain before and people who didn't. We can discuss that. But the acute pain, how we manage it, and then I think what we should do is talk about, is there a transition into chronicity, or are people maybe phenotyped, or just is it bad luck, who knows? And then I would like to, by the end of it, talk about, are there people that maybe should not have surgery? Could we get to the point where you could say, even though your neighbor had surgery, maybe you shouldn't? Is that all right?
Yep. Yes, okay.
So let me kick off. We have, let's imagine a setting with a person who comes in, let's say osteoarthritis of the knee, total knee replacement, and they wake up with immense amounts of pain. Should we do anything, or should they just, non-pharmacological? What can we do to them?
Well, we can do a lot, of course. But it really depends on the person. Well, in acute pain, most important is that we give them analgesics, because acute pain is mainly focused on the somatic dimension of pain, but we should not forget the other dimensions of pain, of course, the psychological, social, spiritual, meaningful dimensions.
What would that look like? So I imagine if, once in a while, I think everyone's trying to have an acute onset of pain. And when it comes acute, we sort of think it will go away, but now that you have surgery, you have a time frame that is at least days, if not a week or two, with pain at certain levels. So could we not use medicine?
Wow.
What do you think? I'm not saying we should, I'm just questioning it.
Perhaps I would like to go a step behind. You're saying patients are in pain. My next question would be, what is the pain doing with the patient? With, for example, the possibility to bend her or his knee. What I want to say is we are looking much more on function than we did, let's say, 10 years before. So I would not only ask for the pain, I would ask what is the pain doing with function and with this person. For example, what we like to ask patients, and what we also discuss with our nurses very often, is to ask, did you wake up because of pain last night? So before we choose the type of pain management, we should get a clearer picture of what the pain is doing with the patient.
To the person,
and also looking on the affective dimension of pain.
So essentially what you're saying is that you could have a person, maybe a fictitious person, but someone who says, I have pain, but it's okay. I can sleep through it, and I'm not
exactly.
worried.
Yeah.
Yes.
And they would have a different treatment than people who are worried
Sure.
and can't sleep through.
Yeah.
Is that what you're saying?
Yeah, that's what Winfried is saying, that we have to make a total assessment of this patient's pain and what it's doing to them. And it can be different for any person.
Yeah.
So we have to assess the pain, what it's doing to that person, and then we should choose treatment. And that treatment can be pharmacological, but also non-pharmacological.
Yeah.
And I immediately see that this could be an issue because back in the day, as you say, there was protocols, regimes, right? So whenever you wake up, you have to take 4 of these and 2 of these and then talk to someone. How would you manage that? Does that take a lot of resources to manage people individually and understand what they need?
I think no. I think it should be, and in many hospitals it is already part of the clinical routine. As I already said, it's only a couple of questions, and it's a type of clinical view on the patient, which is normally done anyway. Yeah? The point is, so far it's often not well communicated. For example, the nurses and also the physiotherapists, they often know very well the situation of the patient, the need for more or less pain management, but it's not well communicated, and the doctors do not really listen. They do their rounds specifically in orthopedics. Everybody knows the rounds are very short, and so I think it's not really time consuming to assess pain and its function. The issue is to organize a hospital or office-based surgery that the information is really translated in action, in pain management.
Yes, and there's nothing wrong with protocols, but the people that work with the protocols, they should know when to divert from it. Because some years ago we always had those procedure-specific protocols, but we want to turn them into patient-specific protocols. And as Winfried always said, I don't think it's very time consuming. I think that it will buy us some time if we do it the right way. But we have to teach our nurses and our physician to do it the right way. And well, in my practice, some years ago, we only asked for pain scores. And there was a protocol that if a patient would score much higher than 4, then we should treat those patients. Whatever he said, if the pain was acceptable or not, and he was functioning or not, we should treat it. But that's totally different now.
And this almost begs the question about the 5th vital sign, doesn't it? So
sure.
People may not be familiar, but there was this idea back in 1996, I think, where the 5th vital sign was, so whenever you talk about respiration and pulse and temperature, you would also ask about the pain. And then if the pain was higher than 6, I think in some states in the US at least, then they would automatically be giving opioids.
Yeah.
Yes.
And
that's
some would
wrong.
argue this was the beginning of the opioid crisis. So how does that look in respectively Germany and Holland? Do you see an issue with opioids? Maybe the first question should be, should we use opioids? Are they effective in the acute setting?
Yeah. Clearly, yes. Yeah, and I think it's not such a bad idea to make pain visible. The problem in the US was not to make pain visible, but to connect a number on a scale with giving opioids. And I think this reaction is a catastrophe and is wrong. But to make pain visible, in principle, is a good idea. And we can see it. You will report on the Netherlands, but in Germany, we use not almost the same amount of opioids than in the US, but we do not have this amount of problems. We do not have thousands of deaths. We do not have patients in the emergency department due to opioid problems. It's the way you treat patients responsibly, and I think it's also an issue of the health system. Yeah? And this is perhaps one of the most important issues in the US, these enormous deficits in the health system.
Yeah. Well, that's the same in Holland. We do not have an opioid crisis in Holland as well, but we are careful because we are looking at the states, of course. But it all depends on how you manage pain in your patients. And I agree with Winfried. I think that we should keep using opioids, but we should use them appropriately and not connected to a number, but just talk to your patients, assess pain, and you can even discuss whether or not you should use the word pain, because there's also some evidence that they maybe just make pain if you use the word pain, like a nocebo effect. I'm not sure if you so if I should explain the nocebo effect.
I assume most people would be familiar with the concept, at least,
Yes.
that if people are more worried, then they might actually have more pain.
Yes, but if you manage it properly, that you ask, you can ask for pain score, no problem. But you should also ask if pain is acceptable, if people can make the appropriate movements, if they wake up at night, and then you have a total assessment, and you have to propose a person-centered approach for that patient.
And not to put words in your mouth, but I assume this is what the non-pharmacological management is all about, talking to the person and making sure you address their worries and questions. And what about so individualized? So maybe 10 years ago, I think it was quite popular with self-administered opioid drops. Is that still a thing?
Yes, in Holland it is, because when you can self-administer your opioids, then mostly you have also a feeling of control, and just that feeling of control also helps alleviate pain. Yeah.
I agree, but you could also think of using other techniques with the same advantage, like transcutaneous electric nerve stimulation.
Yeah. So delivering opioids instead of through a drop, then perhaps through the skin or even the mouth, as a spray or whatever.
And that's excellent.
What would be the difference? Why would that be different?
I refer to this, not to bringing the drug into the body I mean, there's also some technical advantages. What I was speaking about is transcutaneous electric nerve stimulation.
Okay, so non-pharmacologically.
It's exactly where you don't use any drugs, but the current is reducing the pain, and there is good evidence. There's no lobby. Nobody is earning money with this technique. It's cheap, but it also gives control over the pain treatment to the patients. And so this is the same, it's patient-controlled analgesia, but without opioids. And this is something we, for example, in our hospital, we use it even more often than opioid PCA devices.
Okay, so the whole concept of making the person involved in their own treatment seems also to influence the pain they experience.
Yes, certainly. Yeah.
And what about differences? So we now established that opioids are effective. We also know that there is a risk, but there's also immense amounts of side effects. So adverse events, nausea, constipation. There's a lot of things that goes with it, and especially if you have older people and they have nausea or dizziness, the risk of them falling increases. So the package of using opioids is not simple. Could it be, or the question is probably, how different is it from using well-targeted NSAIDs, like, I don't know, naproxen or whatever, or opioids? Are they comparable, or are they significantly different in your opinion?
They're certainly significantly different. But the NSAIDs also have a lot of side effects, and especially in older people, they're, I think, more dangerous than opioids, but that's my personal opinion. But you should balance your
for the cardiovascular risk side.
Yes, for example.
Gastrointestinal. Yeah, I mean, I completely agree. That's what we call multimodal approach, to combine different mechanisms, different drugs. It's also different non-pharmacological approaches to reduce the side effects of each individual intervention. And if this is done for a couple of days, then we see problems, but they are not really frequent. And then, from my point of view, opioids could be used not in all patients, but in a couple of patients safely.
So it's a safe, good treatment for the first few days. So could I represent some of my some colleagues, so primary care physicians? So I'm a physio, but I work with a lot of primary care physicians, and they say that when they receive patients coming out of the hospital after having had surgery, they would be stereotypically, of course, carrying a bag of opioids with them and only showing up for the GP when the bag is empty.
I hope not. But
Do you understand the stereotype?
Yes.
So obviously the right thing would be to not do that, but why is that happening? Is there like a good explanation, or is that simply because people didn't follow the guidelines, or why does that happen?
There's a lot of variation in prescribing opioids after hospital admittance, but we aim to let our patients go home without opioids. Let's set that first. But since the hospital admittance has been so short lately, after the total HIP only 1 day, sometimes you cannot avoid to send people home with opioids, because it's a key, for most surgical procedures, it is the key treatment. But we should use it appropriately, and we should monitor, and we should not prescribe opioids for example, 3 months or something, but just make a prescription for a few days. And of course, that you say that your GP says, well, after a few days, my patients come to me and say, I'm out of opioids, please prescribe me some more. But that's the time that the GP should say, what's wrong there? Because you've only had a prescription for a few days from the hospital. So actually you should go back to the hospital and ask, I need more, is that okay? So I think there's also a responsibility from the hospital itself to monitor the opioids and to follow up patients that are going home with opioids. And there have been described some organizational structures to do those kind of things. They're called pain services, transitional pain services, and I think that's something that we should do more in the future.
And I mean, you mentioned the length of stay, and I think this clearly shows the influence of the health system. In Germany, it's still the exception to send patients home with opioids, but this is partly due to the longer duration of stay in German hospitals. So we will have to discuss this topic, I think, more frequently in the future. On the other side, as you just mentioned, in the German guidelines on acute pain, there is now a new recommendation that surgeons, anesthesiologists should take care to make clear recommendations what happens after discharge of the patient. So inform the GP, inform the patient that, for example, opioid treatment is only planned or for a couple of days, etc., etc. And I think that's also a new development, that we not only look on the beginning of a pain management or pain treatment after surgery, but also think about how to stop it. And
so let's imagine we have a person who comes in and the inflammatory phase is sort of drifting off, and the pain is supposed to be lessened. But now, let's say it's a week, maybe 2, 3, 4 weeks later, maybe even 2 months later, but the pain is still there. It may even be aggravating. Functionally, they're not working anymore. They don't sleep. They're starting to worry. All of that. What do you think is going on here? Do you have any models, any ideas, theories? What goes on? When do people sort of transition into this maybe chronic phase?
Well, we have different models.
In the acute, so maybe shorter chronic period before we reach the 3 months sign.
Well, we have some theories and some models, but actually up till now we do not really know what's happening if these patients before surgery were already prone to have chronic post-surgical pain, because after 3 months we speak of chronic post-surgical pain. Or maybe there's also a theory, because there's a correlation between acute postoperative pain and chronic post-surgical pain, that if patients are not treated in the acute phase and subacute phase well for pain, then maybe there may be a transition to chronic pain.
So if you have intense acute pain, the risk of having longer lasting pain is higher?
Yes, that's true, but we do not know if it's a causation or not. So that's a very tricky thing, and there's been going on a lot of research about this transitional, but we do not know exactly what what the cause is. Yes, but certainly is that there has been something wrong in the monitoring of this patient, because If your patient comes back after 3 months with having chronic post-surgical pain, then I think that's a little bit too late.
Yeah.
Yeah.
So, yeah, go ahead.
Yeah, I completely agree, and I think the problem just now is we know some preoperative risk factors which are related to the patient, like pre-existing chronic pain, pre-existing opioid therapy. These are clear risk factors. There might be also some issues like anxiety or depression. It's a little bit less clear, but there seems to be, at least in some patients, an increased risk. Then we know some intraoperative risk factors. It's on one side the surgery itself. We know the rate of transition from acute to chronic pain differs enormously between surgeries. And
surgeons and surgeries, or more surgeons?
That's a very good question.
Yes.
Because
Definitely.
there is not that much research so far on the surgery itself. So we know in some surgeries that less invasive techniques like laparoscopic techniques are reducing the risk, but this is not true for all types of surgery. So there is still also the use of devices, robotic surgery, length of surgery. All these are potential risk factors which are not so clear. And then we have the phase after surgery. And from my point of view here, we have still a very limited knowledge on additional factors like inflammation, like mobilization or failed mobilization, but also like psychological factors. Some patients develop depression, anxiety after surgery. They are completely okay before surgery. They develop these issues after surgery. And from my point of view, we should focus much more on factors which only show up after surgery and which can only be detected after surgery.
Yeah. And are you talking from a clinical perspective or from a research perspective?
Both.
Both.
Yeah,
Okay.
both.
So I assume what you're saying here is that if we manage the person before surgery as well as possible, reduce the pain, give them all the tools they need, maybe take care of the worries, maybe even focus on sleep, things that will benefit healing, then we assume that the risk of having longer lasting pain is less.
Yeah.
Yes.
Then during surgery, there are things that can be done. So I guess the body of evidence would be on nerve sparing techniques.
Exactly,
So instead of cutting nerves, try
Avoiding
not to cut nerves or
damage.
not putting in meshes that creates inflammation, that sort of thing.
And specific types of anesthesia, like regional analgesia, anesthesia, ketamine, potentially IV lidocaine. So I think the anesthesiologist.
And so using that, is that beneficial?
Yeah.
Okay, so
Which
giving
seems to-
ketamine,
yeah. In
blocking the NMDA receptor?
The effect size is small for each of these single interventions, and not all trials have shown an advantage, but almost no trial has shown a disadvantage. So there also might be the issue of responders and non-responders, but in principle, regional local anesthesia, ketamine and IV lidocaine are the most, and perhaps pregabalin, gabapentin for some patients, specifically if they develop neuropathic pain, are the most promising candidates for preventive strategies during.
So what you're speaking is this
anesthesia.
mechanism-based approach where we try to find out what is going on. But pardon me, because I'm not up to date with the literature, but I remember back, which is going to be again 10 years back, I think, there was a series of trials using ketamine that were retracted. And I thought, and this is my not understanding the literature as it is today, I was understanding that there wasn't any good evidence suggesting ketamine would be helpful, but you're saying it might be?
There are a large number of RCTs, and not all of them are successful, but in large meta-analysis, ketamine, gabapentin, pregabalin, and as I already said, these blocking techniques have a certain, if you put everything together, they seem to have a certain degree of risk reduction. It's not large, you cannot prevent it completely, but from all interventions we know, and opioids, for example, they do not have such an effect. They have never shown a preventive effect on chronification, but these interventions I just mentioned, they have, at least in some patients and some types of surgery have shown a certain preventive effect.
Yeah, but I think it's very important what you say, Winfried, in some patients, because all the studies done, we've put all the patients on one big pile, but you should look at responders and non-responders, and something that has not been investigated very well is the combination of certain techniques, because some effects may be small, but they may be cumulative if you put them together.
So putting on your epidemiology hat, could you say something about the people who maybe we should be more careful about in the preemptive phase or the early phase?
Yes, of course, but there have been a lot of studies about the risk factors that Winfried just mentioned, and that's only in the preoperative phase, and we can, well, not all risk factors can be managed. For example, the female gender is a risk factor. Well, sorry, but we can change that, but that's a little bit different. But there are some minimal risk factors about the psychobehavioral risk factors, for example, anxiety, depression, catastrophizing. You can do something that makes people relax, of course. But what Winfried also told us that there are other risk factors during surgery and after surgery. Sometimes people just get anxious after surgery. So we should not focus only on preoperative, but also on the postoperative. Yes.
And I guess what I'm taking from this is also that whilst we know a lot, we also know that we don't know the trick.
Yeah.
Sure.
So we can't prevent it, as it were, but you are looking into it. So what about the sort of final question here would be, are there people, or would there be people, let's say in a near future, like 5 years from now, would it be possible to talk to a person? We can talk about osteoarthritis of the knee again, perhaps, or a lumbar spine surgery, where the effect sizes for lumbar spine surgery, for instance, is quite low, and for knee osteoarthritis can be very high. So there may be two very different cases. Would it be possible to look at the individual and advise against surgery because of a increased risk of post-surgical pain?
Yes, I think so.
Yeah?
Yes, because I've talked earlier about the person-specific treatment. So you should, before surgery, you should just put all the risks together, but also the benefits. And well, there may be some persons that are already for 2 years in pain, and there may be so much risk factors that they will even get more pain after surgery that I can imagine to recommend not to have surgery. Yes.
Yeah, I mean, as you just mentioned, we have this couple of pre, intra, and postoperative factors. I'm convinced that preoperative factors will only explain or predict partly the success of surgery or the risk of chronification. And it is hard to say to something, don't do surgery. It always depends on type of surgery, and I think always the indication for surgery should be done very carefully.
Taking into account all factors.
Yeah. What we will be able to do in the future is to identify patients at increased risk and to treat these patients extremely carefully. For example, reduce opioids. If they are on opioids before surgery, there are some hints that it might make sense to reduce opioids before surgery. So take another 4 weeks before surgery is scheduled and reduce opioids. This could be one, or to do some psychological treatment for anxiety, for depression before the surgery starts. I think this is the future of preparation or of reduction of risk. To say to something, don't do surgery or don't undergo surgery, that's a little bit problematic, but I think we will have specific preventive measures, protocols for patients at increased risk, and this might be followed by another date for the surgery, and then we can hopefully reduce the increased risk in these patients.
Yes, but from an epidemiologist's point of view, our prediction will not always be 100%.
Yeah.
So that's also very difficult, because we predict that 90% that you will be worse after surgery. But will it actually happen? That's what Winfried also said. If we make a full personalized care plan for this patient, and we put in pharmacological, non-pharmacological interventions, and we give this patient time to work on diminishing risk factors.
Yeah.
Who knows?
And again, I think we should say it out loud because there's no surgeons in the room. Neither of us are against surgery per se, so surgery is beneficial. But for some people it's unhelpful and it might even make them worse. And what I take from you is that it's difficult to say who they are, but in the future we might be better at it. But I will come back to your response. I think it's an interesting one because, and whilst that may not be our expertise, why should we not advise against surgery? I guess the point here is that you would advise against other kinds of treatment for certain people, and not, doesn't have to be a yes or no question, but could we be at a point where actually it would be more beneficial not to have the surgery, even if we are just evaluating risks? Or do you think we won't ever be there?
But I think the patient should decide. I think that it's our role just to inform this patient of all the benefit, but also the disadvantages, with all the knowledge that we have and what we don't have.
And I mean, I'm not a surgeon, so I think it's a little bit, I can give advice, as you said, to the patient and to the surgeon, but I'm not a surgeon. It's not my role to say you should have surgery or not. I can make clear, like we do it in anesthesiology. If there's a patient in a very poor condition, we also say the risk is increased, let's discuss. Let's try to shift the date of the surgery, etc. I think this is our role. Our role is not to say surgery should not be done. And as I already said, the indication for surgery is always something which should be done very carefully, and before we do surgery, we always should try to do whatever we can do to solve the problem with less invasive techniques. That's not different from any other indication for invasive interventions.
Yes.
So, just a final question. Then this is something I've been pondering around for a while, because it's almost as if when non-pharmacological doesn't work and when pharmacology has to give up, then surgeons seem to be the ones to blame, or the patient ends up with the surgeon, right? Is that in itself, you think, part of a problem, that we put the surgeons at the end of the line instead of maybe putting them in the front, where actually they may be more beneficial? That's my perception. I don't know if you agree or disagree with that.
Actually, I think that we should put the patient in front.
Well, we couldn't disagree with that.
Sorry.
Now, I was talking more in terms of who they meet first. So, for instance, there are. So we now know that there are certain surgeries that are not effective, so we can rule those out. But there are some that are effective in some people and not in others. But there's also this time frame that we talked about, and maybe if you do surgery when you have had pain for 6 months or more, the risk of having a beneficial effect of surgery reduces. So could we be so good at what we do that we could tell the patient, if you want surgery, do it now instead of waiting?
I think this is a very good question. In some areas we already do this. There are data in certain types of orthopedic surgery that there is a too late and too early phase for surgery. But I think the main message is we have to include surgeons in these discussions. And as discussed in one of the talks yesterday, also when we set up a transitional pain service, why not do it together with surgeons? And I think this is perhaps the main message. These issues should be discussed with everybody who's involved in the care of the patient, and the surgeon is not always involved, and I think this is also our responsibility. The pain community should perhaps more closely discuss this with surgeons.
I think that's a great shout out. So anyone who's a surgeon or knows a surgeon, bring them on to the conference. We need them, and we should reach out. I completely agree. So any last thoughts? Anything you want to get rid of before we end the session?
Well, I have a lot of last thoughts.
Yeah.
But I think that the main key of my lectures here will be to look at the patient, what's good for him, educate him well, and take into account the health literacy of the patient, adjust your pain education and all the benefits and advantages of treatment to the patient's level, and make sure that he is able to make a good decision.
Yeah, you're opening up for a whole new avenue of questions there,
Yeah,
but
yeah, yeah.
that would be for another time.
Yeah, sorry.
Great comment, yeah.
Yeah, and I would add measure outcome. Yeah, I mean that's my belief. We should measure what we are doing, and we should ask our patients, and then
Patient-reported outcomes.
patient-reported outcomes, and then we have a really clearer picture of what we are doing and where we have deficits and where we are doing well.
I think that's a really wonderful ending. So let's have a deeper look at the patients and find out how our treatments work. I think that would be a good way to stop this interview. I thank you both for participating, and I wish you a good conference.